Good morning, everyone. Happy Tuesday. I'm Dr. Martin. Welcome to the Institute of Regenerative Education. If you all haven't been on this platform before, we are most humbly honored that you have joined us. My research institute, Kingston and Cufflinks Research, and I'm wearing my cufflinks my daughter gave me for Christmas. We have a boxer. His name is Kingston. That's where the name comes from. I also did my third year of medical training in Kingston upon Thames. It's also where I met my much better half, Dr. Mary Ann Martin, who's been my wife and soulmate now for almost 25 years. But this is our educational platform for all things biologics. Now, we have about 80, 90 hours of content in this Facebook group, and we have very comprehensive protocols. Any of your reps from Platinum Biologics can send you. Understand that this platform is an open platform and you're able to check everything that I have to say. There will be peer-reviewed references below this lecture so that you know that's just not my opinion. This is what the literature demonstrates. But this is as close as we get to actionably educating providers on how to use biologics from a common sense standpoint. And I want to go through a few things. We did a lecture probably 6, maybe 8 weeks ago called Aesthetic Essentials, and we're following up on that lecture today with Aesthetic Essentials number 2. And tomorrow, if I have time, we'll do Aesthetic Essentials number 3. If not, we'll do it next week. My plan today was actually to do a whole lecture on microneedling because you can really start an aesthetics practice with a $120 microneedle pen and a little bit of education. You don't need a $150,000 RF microneedle machine. You don't need a $70,000 CO2 machine. You don't even need Botox to have a very, very successful practice. But in our more integrated cosmetics practices, in our dermatology clinics, I'm seeing growing frustration. And the growing frustration is predicated on the adverse event ratio, number one. And number two, the parity of options, meaning there's just not a lot to choose from, and the outcomes really aren't that great. And that's really what's upsetting people the most. You know, we're in the United States. If we want to go for, lunch, we've got 30 different fast food restaurants we can go to. There's probably 4 or 5 great, Asian joints you can go to. If you want Italian, you can get Italian. If you want a steak in the middle of the day, you can get a steak. If you want a great bowl of ramen, you can get that too. Do we have all of those choices when it comes to aesthetics? Actually, we don't. There are very few products that are on the market that are getting really good results and that don't carry significant risk of adverse event. Now, a lot of those are touted and they're exciting and they're hot, please, spray some salmon sperm on me and drive it into my face. That's what I want right now. I'm going to get in my car and drive to a clinic and I'm going to spend $1,200 for you to smear salmon sperm in my face. I think it's moronic, but it's marketed well and it's hot and it's exciting. But, just like Arby's, do they have the meats? Are they really seeing great results? Lips is the same. We're seeing all sorts of things put in the lips. There have been complex and cross-linked HA injected in lips now for probably 10 years. There are some estheticians and some plastic surgeons and some dermatologists that just do a wonderful job with this. My partner here in Las Vegas, Michelle Norvell, she's a nurse practitioner. She's probably some of the best hands for lips in the West Coast. She trains doctors all over the country based on technique. But what about product selection, product choice? What's new, what's hot? Well, before we get into what's new and what's hot, I think it's terribly important we go back to basics. And so if you've seen anything on this institute, I focus quite a lot on clinically relevant, evidence-based biologic applications. If you don't understand why you're doing it, why the hell are you doing it? Just because some rep came in with a box of crumble cookies and they said it was great and they gave you an industry paper paid for by the company, done by researchers employed by the company who got bonuses if it was taken to market, and then who get extra money to run around and sit at steak dinners and say that it's the best thing since sliced bread? Yeah, I don't know. I mean, I've attended drug rep dinners for I don't even know how long, for probably 20 years out of the 25 I've been in practice. And every time I ask hard questions at these aesthetic lectures, the common response is, we'll get back to you. I'll circle back. We hear newscasters use the whole circle back thing. And now that's become a common phrase from supposed scientific experts at these cosmetic conferences and sales rep dinners, because they don't have the meats. They can't tell you how and why it should do that. One of the more common questions I ask is, I saw in your notes that product stimulates elastin. Can you show me how that happens? Oh, well, it was in the paper. No, it's not, because I went behind the paywall and I downloaded the full paper for the product. And yes, you observed increased elastin in your in vitro, in vivo study, but there's no way to replicate that in vivo, in vitro in common practice in something like, radius, right? Which is now being used everywhere, including the lips. I don't know if you know this, but there are people using dilute radius in the lips. I think that's insane, right? Calcium hydroxyapatite, bone. I was at a lecture 2 months ago, and I just asked a simple question. I said, the calcium hydroxyapatite that is in radius was initially approved for HIV bone wasting in the face. And now we have protocols to use dilute radius for a BBL, where you're doing a tulip approach, right? To increase subcutaneous mass in aesthetic appearance of the butt. I'm just curious here. I don't have a whole lot of elastin in my femur or in my tibia, because bone and even bone marrow derived stem cells don't stimulate elastin. So I'm just a country city boy from Missouri. I'm not the smartest guy in the room, never gonna be. But just explain to me in terms that I can understand how calcium hydroxyapatite, how bone somehow stimulates elastin. We'll get back to you on that. Oh, can I get your email? And they make a big production of coming over and putting my email in on their iPad. Then I know that it's going to go into, kind of the same place that the letters to Santa go, right? Wherever that is. I'm sorry if somebody's watching this with their 3 or 4-year-old. But, just like believing in Santa Claus, that's kind of like believing that you actually get elastin formation from some of these complex and cross-linked HAs, and you actually get that from something like dilute radius. How exactly does that work? Are there elastin precursors in that product that are somehow going to stimulate tropoelastin and then give you elastogenesis? Yeah, no. Yeah, they're not there. So how exactly did that happen? Well, if you observed elastogenesis, that's great. And I get the whole, well, A plus B equals C, and so A must equal C. But you have to explain that to me in terms that I can understand. And moreover, you have to show me that in common practice that I'm somehow going to get more elastin using your product. And the patient's not going to get little nodules of microcalcification all through the skin that's now very visible on facelift surgeries and pointed out by numerous different cosmetic and regenerative surgeons where they're doing deep plane facelift and they can actually show you all the dilute radius in the face, the little globules of microcalcification everywhere, dramatically changing the architecture of what should be type 1 and type 3 collagen and elastin in the dermis, and now it's just not that. So let's just talk about natural history as it pertains to lips. Because of all of the cosmetic applications, lips is probably the most limited. You have the fewest options. And so let's just review this, right? We know that as a natural course of aging, we get loss of pinkness and redness in the lips, right? They start to get dusky, right? We start to get modeling of the lips. You get brown spots in the lips. The epidermal thickness decreases, your blood flow decreases, your collagen decreases, the density of blood vessels decrease. All those things happen. How do we perceive that when the patient walks in the office? Well, we perceive that clinically in a couple things, right? We start to lose the vertical height of the upper lip. We start to see an elongated philtrum. The distance between the nose and the upper lip, this becomes elongated. Histopathologically, we start to see things like reduced density of blood vessels in the vermilion. And so this is a cross-section of the lip. This is your epidermis, your skin, right? This is your intraoral labial mucosa. This is your fat. This is your orbicularis oris muscle, right? But this vermis is really what we're after because the vermilion border is where we see most of our pathology. We start to see loss of density of blood vessels. We start to see thinness of the epithelial layer. This is a problem. And the reason it's a problem is that this wonderful pink color to our lips, the smooth texture to our lips, that really beautiful height of the upper lip, Cupid's bow, the outward protrusion of the upper lip, all start to deteriorate as we get older. And so if this is the pathology, if the pathology is a loss of elastin, a loss of blood vessels, both in diameter and in density, as well as a loss of tissue integrity, meaning that your epidermis gets thinner, meaning that you've lost elastin, but you're also losing type 1 and type 3 collagen. If this is the pathology that gives us this clinical picture of a flattened, of a smashed, of a longer upper lip, and a longer distance from the upper lip to our nose, that increase in the philtrum, what exactly from a supplement standpoint is going to be the answer? Well, let's just look at a couple things, all right? Say I put a cross-linked HA in the lip. What is that cross-linked HA going to do? Cross-linked HA is going to be hydrophilic. So water is going to come into that cross-linked HA. Now, will that add volume to the lips? You betcha, right? Transiently, it will add volume to the lips. What will it do for elastogenesis? I'm sorry, but nothing. You're not going to get elastogenesis because there are not any growth differentiating factors in cross-linked HA to stimulate tropoelastin. What about angiogenesis? Are we going to see any angiogenesis with cross-linked HA? No. There's no CD31 in cross-linked HA. CD31 is what we commonly look for as a biologic marker to show increase in neovascularization and angiogenesis, CD31 plus, right? Do we see CD31 plus after administration of cross-linked HA? No, we don't see this either. Well, we know that cross-linked HA is going to bring in water, but is there any evidence that cross-linked HA has collagenous growth factors, either type 1 or type 3 collagenous growth factors? I'll wait. No, none at all. So your primary determinants of age-related changes to the lips are threefold: loss of elastin, decreased blood vessel density and diameter, and loss of tissue integrity, in particular type 1 and type 3 collagen. And the main product that we're using to put in the lips affects change in none of them. None. So you may ask yourself, like I do, why the hell are we doing it? I mean, it's the definition of insanity, right? To do something, not get the intended outcome, but continuing to do it. Well, I think it's been done for so long because it's the standard. It's the norm. It's what everyone does. And if you repeat a lie often enough, people believe it. Oh, well, let's just put some filler in your lips, right? Now, without question, you can achieve a cosmetic appearance with cross-linked HA. You can achieve a cosmetic appearance with dilute radius. Are you achieving a biologic appearance? Are you doing anything at a histopathologic level to change or actually regenerate elastin, blood vessel density and diameter, or tissue integrity? I would argue you're doing none of those things. So you are temporizing, right? We're putting a Band-Aid on a gushing, bleeding wound. That's all we're doing. And we're getting paid for it, so we're making money, and the cosmetic appearance is lovely, but the cosmetic appearance goes away. I mean, no offense, I think she's a wonderful human being, but look at Pamela Anderson. Look at what happened to her after she stopped all the fillers. She had plastic surgeons go in and dissolve all of her filler through her entire face because she got the classic filler face. She had filler going everywhere. I saw a picture of Zac Efron yesterday. Maybe it was Photoshop, but I mean, he looks, I don't even know. I mean, he looks so swollen and so artificial. I mean, it's terrible. So whoever his manager is, I feel bad for both of them because he's being lied to, number one, about what his appearance should be. And number two, whoever's doing that to him has convinced him that the transient aesthetic benefit outweighs the holistic prevention-based care for the patient. And I think this is where the line is drawn. This is where the line's drawn. I think, and, I'm happy to be the bad guy, and I guess I've gotten better at that because I'm just very blunt, but have we sold our souls for transient aesthetic appearance? Over prevention-based care and the conscientious practice of medicine for a patient? I would say that we have. Hollywood, news, print, advertising, I think it's all contributed to this. I think a lot of money's been made. A lot of money by estheticians, by companies selling temporary products. But I guess, is there moral high ground here? Should we be doing better? Can we do better? Yeah, I think we can. From a practical standpoint, let's just look at a few basic elements. And I'm going to allow you to draw your own conclusions. We know that there's a risk of vaso-occlusive crisis with cross-linked HA. We definitely know there's a risk of vaso-occlusive crisis with dilute radius, right? There are people that are throwing platelet-derived growth factor in lips as well. This is the hot newness. PDGF. What is PDGF? Well, I think you should all look up what Regenerative is, because it's not human. Regenerative is recombinant platelet-derived growth factors extracted from yeast. At best, it's a bovine product. At worst, it's a completely synthetic yeast-derived platelet growth factor that comes ultimately from E. coli, a bacteria that they use to stimulate yeast formation, and then from this yeast formation, incubate these platelet-derived growth factors that are probably coming from bovine source, not human source, right? Now, there may not be a risk of graft versus host because we're not going to see all the antigens and, other RH incompatibilities of blood, but the stuff's thick. It's really thick. Can you get a vaso-occlusive crisis from PDGF? Yeah. What exactly do you dissolve that with? Hell if I know. Is hyaluronidase going to break it down? Well, there's no HA in it. So what do you dissolve it with? I mean, there are some preparations that are platelet-derived growth factor plus HA, and so that would be reasonable, right, to use hyaluronidase, and maybe you dissolve it out. Maybe you don't. I gave a lecture on autism Friday. Over the weekend, I talked to a doctor, very pleasant doctor, who saw the lecture and called me on my cell Sunday morning to let me know that he was aware of a child that had gone overseas and had an intrathecal application of stem cells And that 3-year-old died on the table. On the table. This is not that lecture. But what it is a lecture specific to vaso-occlusive crisis and are there options. It is a prevention-based lecture based on the histopathology that's causing age-related changes to lips. So let's just look at something like Wharton's jelly. Okay, what do we have in Wharton's jelly? Well, we have HA, extremely concentrated HA. We have type 1 collagen and we have type 3 collagen. All those are wonderful things. Okay. What do we also have? An umbilical cord-derived tissue. Well, we have growth differentiating factor 11. What does growth differentiating factor 11 do? Oh, it just happens to stimulate tropoelastin. Oh, what is tropoelastin? The precursor for elastogenesis, found in 2 structures, the umbilical cord and the intermediate layer of the placenta, and nowhere else. Well, does it do anything else? Because this is kind of fabulous. Well, umbilical cord tissue, and specifically umbilical cord-derived exosomes, have exceptionally concentrated amounts of placental growth factor and some of the highest concentrations of vascular endothelial growth factor. Okay, well, we need elastin. Oh, we got growth differentiating factor 11. So there we go, right? We need blood vessels, right? We need angiogenesis to improve the loss of density and diameter. Well, here we go, right? And oh yeah, we need some collagen, right? Because we're losing tissue integrity in the lips, because we're losing the structural tissue of the lip, and oh, there we go. Is it that far a bridge to cross? It's not. Now the question is, practically speaking, how do we do this? Because Wharton's jelly has extracellular matrix. I didn't write that, right? It's got extracellular matrix. And because it's got extracellular matrix, if I were to put that in a lip, there's a potential of a vaso-occlusive crisis. That's true. What if I was to use an aqueous form of Wharton's jelly from Platinum Biologics that's 1 cc, which is the recommended volume for lips, that just happens to be aqueous, be extracellular matrix free, high concentrations of collagen-based growth factors, high concentrations of growth differentiating factor 11 exosomes, and won't cause a vaso-occlusive crisis. It's kind of hot. It's kind of sexy, right? So now if I do a set of lips and the product's comparable to everything else I'm putting in the lips, and there's no risk of a vaso-occlusive crisis, well, that reduces my liability. That reduces my potential malpractice. That's a good thing. Well, Dr. Martin, am I still going to get this big duck lip thing? No, you're not. You're not going to get that big artificial, I can't remember the name of the movie. Who Killed Roger Rabbit, right? You ever saw the Looney Tunes or I don't think it was Disney, but Who Killed Roger Rabbit? There's a female, in the movie, I can't even remember what her name is, but she's got these big, huge lips, right? Are you going to get that? No, you're not going to get that. But many aesthetic clinics have started to move away from this big, overfilled look. started in South Florida, in very wealthy communities in South Florida. And I know that because I was talking to one of the clinics that was doing it. And their clients were coming to them saying, hey, look, we're kind of done with this. We don't like this whole overfilled look. Then it jumped very quickly to Manhattan and Martha's Vineyard. And then it jumped all the way over to the West Coast. And I started talking to a clinic on Rodeo Drive that wanted more natural looking aesthetic practices. And they wanted more natural biostimulants that were prevention based and not just a temporary fix. Now, are you going to make as much money doing this? Well, you probably aren't going to fill the lips every 3 months and then do it in perpetuity for 4 or 5 years. Ideally, a natural biostimulant fills the deficit and then doesn't overfill, because there isn't any of this propagation, this filler face phenomenon with natural source biologics. And so maybe it's 2-3 applications the patient does beautifully, but based on age-related changes, maybe they need a touch-up once a year, all right? Maybe it isn't the huge moneymaker that your synthetic HA is, but will you retain that client longer? Will the client ultimately be happier if you take the time and effort to explain to them from a histopathologic level what they're experiencing just looking in the mirror? Because they're going to tell you, hey, look, I'm thinking about, a little surgery to do a lip flip, right, and shorten my philtrum. I'm thinking about, doing something to kind of, help with the marionette lines and the smoker's lines. And I don't even smoke. I'm thinking about tattooing my lips because I've lost all the pinkness to my lips and I'm starting to get this modeling of my lips and I don't like it. So you can tattoo the lips and you can cover it up. You can do the lip flip and hopefully the surgeon does a good job and tucks that suture up under the nose nicely. You can do, filler in and around for those marionette lines that will eventually migrate, lose its efficacy. Or you can try a more natural biostimulant that by its very nature addresses the most common problems that we see with aging. And ultimately, the decision's yours. I'm Dr. Martin. Have a very blessed day.